Hello, my name is John DiBaise. I'm a professor of medicine and a consultant in gastroenterology and hepatology at the Mayo Clinic in Arizona. Today's course is just one in a series of subjects brought to you by Channel 1, On-Demand Nutrition Education. Today we're looking at the use of parenteral support in individuals with short bowel syndrome. This is based on an article that I co-authored called Gut Instinct: Navigating the Landscape of Parenteral Support in Short Bowel Syndrome, published earlier this year in Nutrition and Clinical Practice. Now, this article covered many topics in detail that are listed in this slide. Because of the time limitations I have, I'm going to be covering the highlighted areas, the basics of short bowel syndrome, when and where to initiate parenteral nutrition, and finally, I'll discuss some issues related to weaning of parenteral nutrition and monitoring. So to begin, short bowel syndrome is a malabsorptive syndrome generally related to reduced gut length. Now, because of the very wide range in the normal small bowel length in individuals, anywhere from 300 to 800 centimeters, putting an exact number to what defines short bowel syndrome has been difficult. And in the past, it generally was a functional definition. In more recent years, though, the experts in this area have kind of come up with a consensus that anything less than 200 centimeters in an adult, that is small bowel, less than 200 centimeters of small bowel remaining in an adult, would be defined as short bowel syndrome. Now, short bowel syndrome occurs in about 15% of adults undergoing intestinal resection. 75% of these result from a single massive resection, whereas the other 25% result from multiple resections. For example, in a patient with Crohn's disease who's had multiple bowel resections. About 70% of those with newly acquired short bowel syndrome are able to be discharged from the hospital, meaning that 30% are unfortunately unable to leave the hospital as they're deceased. And so many of these, if not most of these patients, the 70% that are able to be discharged from the hospital will be discharged with parenteral nutrition support. So there are a number of causes in short bowel syndrome, and you'll recall that short bowel can occur in both infants and adults. In infants, they're mostly congenital anomalies or the necrotizing enterocolitis, whereas in adults, the most common causes are multiple resections for Crohn's disease, mesenteric ischemic events, such as superior mesenteric artery thrombosis, resections in the setting of radiation enteritis, and postoperative catastrophes, as well as trauma. So we need to differentiate intestinal failure from short bowel syndrome. Intestinal failure refers to the inability of an individual to maintain their nutrition, hydration, electrolytes, micronutrients while consuming a normal diet, and implies the need for parenteral support. There are different classification schemes used to classify intestinal failure. One of the more common ones is acute, prolonged, and chronic. Chronic is where short bowel syndrome falls in, and it is in fact the most common cause of chronic intestinal failure. Pathophysiologic classification would include different categories, such as short bowel syndrome, in addition to intestinal dysmotility, like chronic intestinal pseudoobstruction, small bowel mucosal disorders causing severe malabsorption, chronic mechanical obstruction, and so on. And then there's clinical classification of intestinal failure that really kind of looks mostly at the volume of parenteral support required, as well as the energy needs that's provided through this parenteral support. So the major goal here is to convert intestinal failure, meaning the need for parenteral support, to a state of intestinal insufficiency or deficiency where parenteral support is no longer necessary. And this is usually done by trying to optimize a variety of things, optimizing the diet, optimizing oral fluids, optimizing various conventional symptomatic medications such as antidiarrheals and anti-secretory medications. And then sometimes surgery is necessary and can be helpful in some of these individuals. The classification of just short bowel syndrome is most commonly based on the anatomy, the bowel anatomy. So there's divided into groups 1, 2, and 3. Group 1 is the angiogynostomy. Group 2 is the jejunoclonic. And group 3 is the jejuno-ileocolonic. And based on the remaining anatomy, you can determine some aspects of their overall prognosis as well as their complications there that they are at risk for. So, for example, group 3 is the jejunal-ileocolonic. So they have a segment of jejunum, a segment of usually the distal ileum, and all of their colon. And this group has the best prognosis, and that is contrasted with group 1, the angiogenestomy, where they just have a section of jejunum with a stoma. And depending upon the length of jejunum remaining will determine their ultimate prognosis in terms of with regards to needing permanent parenteral support. So now getting into parenteral support in short bowel syndrome. As I mentioned before, virtually all short bowel patients will initially require parenteral nutrition. Most will require parenteral nutrition at home after they're discharged from the hospital. As I note, parenteral nutrition is usually initiated in the hospital setting and then transitioned to the home setting. But occasionally, parenteral nutrition is not provided after discharge. And this, in some cases, can lead to progressive weight loss, macro and micronutrient deficiencies, acute chronic dehydration with acute and chronic kidney injury. And just for your information, parenteral nutrition dependency in non-malignant causes of short bowel syndrome at 1, 2, and 5 years has been shown to be about 74% at 1 year, 64% at 2 years, and about close to 50% at 5 years. And parenteral nutrition dependency is reduced when the remaining colon is less than 57% and the small bowel remnant is less than 75 centimeters. So one thing before we move on is just the appropriateness of home parenteral nutrition. This is something that needs to be determined before these patients that develop the short bowel syndrome and need for parenteral nutrition are sent home from the hospital. Is their home setting appropriate? I've provided a list of things in their home assessment to determine if these aren't present, you should really think again about sending them home with parenteral nutrition support. Other things, is the patient willing to take on the burdens of managing themselves? Do they have social support or a caregiver present to help them? Will their insurance cover this at home? Do they have an appropriate central venous catheter for the administration? Is the parenteral nutrition formula already optimized and transitioned to an overnight cycle? Are they clinically stable? Is a monitoring plan in place and a multidisciplinary care team in place? And finally, has there been proper education given to the patient and their caregiver? All of these things really need to be sorted out before sending this patient home on parenteral nutrition support. So there are a variety of clinical factors that can predict the likelihood of permanent need of parenteral nutrition support, and in a subsequent slide, I'll review a list of these. The remnant bowel anatomy in short bowel syndrome is perhaps the most important influencer of the ability to maintain nutrition and hydration orally, and whether they will subsequently develop chronic intestinal failure, meaning the permanent need of parenteral nutrition or parenteral support. So the volume and type of parenteral support are also indicators of the severity of short bowel syndrome, as I alluded to previously. So in terms of these clinical factors that play predictors of the need for permanent parenteral nutrition, if the remnant bowel anatomy and they have an angiogenestomy, if they have less than 100 centimeters of small bowel remaining, they are likely going to require permanent parenteral nutrition support. On the other hand, if the jejunal colonic anastomosis, less than 65 centimeters of jejunum remaining, or in the case of a jejunal ileocolonic anastomosis, less than 30 centimeters of small bowel remaining is predictive of requiring permanent parenteral nutrition support. Other factors, is there residual disease in the remnant bowel, such as, for example, residual radiation injury or Crohn's disease, active Crohn's disease? Absence of a colon is an important predictor or risk factor for the need of permanent parenteral support. The degree to which adaptation has occurred, intestinal adaptation has occurred, that references kind of the duration of time that the person has been on parenteral nutrition support, given that adaptation occurs over anywhere from 1 to 2 or 3 years even, depending upon the age of the individual. So the longer the person's on parenteral nutrition support, the less likely they are to be able to wean completely from parenteral nutrition support. So when should a person consider IV fluids or parenteral nutrition in somebody with short bowel syndrome? If they have weight loss and are malnourished, if they're chronically dehydrated, if they've developed recurrent episodes of acute kidney injury or have developed chronic kidney injury as a result of this dehydration, if they have symptomatic electrolyte derangements or failure to thrive. Any of these things may be an indication to start parenteral support. IV fluids alone, with or without electrolytes, may be indicated in those who have symptomatic electrolyte deficiencies without weight loss or dehydration. When there's acute illness, as such that the stool output acutely worsens, or during hot summer months, increased fluid and electrolytes may also be needed in somebody who's already receiving parenteral nutrition support during the overnight hours. And IV fluid is also sometimes still needed in patients who are successfully weaned from parenteral nutrition. So you've got them off the nutrition side of things, but they still require the fluids. This brings up where to initiate parenteral nutrition. Most of the time this is done in the hospital setting, but occasionally this can be done in the home setting. This can obviously avoid the need for hospitalization, reduce costs. But in most of these patients with short bowel syndrome, it's generally not a good idea to initiate this at home. Who are you going to consider a home initiation of parenteral nutrition? These are patients basically who have previously been on parenteral nutrition and tolerated before, and they have not gotten to a point where they're having significant GI losses or haven't had significant weight loss, such that you're worried about refeeding or electrolyte problems. So in addition, if you're going to consider home initiation, the appropriate protocols must be in place with the infusion company and the managing teams with roles and responsibilities fully delineated. So next we come up to the parenteral nutrition monitoring. What things are you going to monitor with these patients on home parenteral nutrition? And this is, you're going to do some laboratory studies, and the frequency and the exact labs that you obtain are going to be based on the clinical stability of the patient. So in most cases, you're going to be checking anywhere from weekly initially to monthly, sometimes less often, routine chemistries, basic metabolic panel, for example, with magnesium phosphorus levels, a full chemistry panel, a comprehensive metabolic panel, at least monthly, CBC at least monthly, liver tests monthly, triglyceride levels possibly monthly, and then micronutrient levels that I've listed in this slide. You know, these are going to be checked less often, but they need to be checked at least yearly and perhaps more often in those who have who've had deficiencies identified and you're trying to replete them. And then also think of monitoring the bone mineral density periodically, and central venous catheter care weekly also needs to be continued in these patients. So the last thing I'm going to discuss is parenteral nutrition weaning, and this refers to the safe and durable transition from parenteral nutrition to another form of nutrition, typically oral nutrition, but occasionally you're going to be transitioning to enteral nutrition and sometimes IV fluids. So this will allow them to resume a more normal lifestyle and improve their quality of life. And potentially it's going to reduce also their complications and improve their overall survival. So the goal of parenteral nutrition weaning is to provide the minimum amount of parenteral support needed to maintain their weight and hydration. So in other words, you need to set a realistic goal, not only with yourself, but more importantly with the patient, that the reduction may be complete, but often is only partial. Such that, you know, for example, if they started at 7 nights a week of parenteral nutrition, you may only be able to get them realistically down to 3 or 4 nights of parenteral nutrition. So they're still going to require something. Now, parenteral nutrition weaning is best done in a multidisciplinary setting with experienced healthcare providers, requires motivated and adherent patient who requires trade-off or who recognizes the trade-off of not being on parenteral nutrition, meaning increased oral intake, increased medication use, increased expenses. So parenteral nutrition then may commence when the patient is clinically stable, in other words, nutritionally optimized and able to take adequate oral without excessive diarrhea, and maintenance of their weight, urine output, and laboratory studies. This entails a gradual reduction of parenteral nutrition volume and/or calories over a period of time. So this can be done by decreasing the parenteral nutrition by a day a week versus reducing an equal volume throughout the days of the week that the individual is receiving the parenteral nutrition. And this can be done then every, say, 2 to 12 weeks, you can make these changes. And in this next slide, it's taken from the article that I referred to earlier. This kind of goes through it in more detail. So you initially, in the process of PN weaning, you attempt to optimize their nutrition, hydration, maintain their weight goals, optimize their medications, and you educate the patient, establish their goals, and then the patient now is ready to wean. And so, are they at risk for volume depletion? If yes, then it's advised that you probably go to the weaning strategy of reducing the infusion volume equally throughout the week by 10 to 30% equally throughout the week. If, on the other hand, they're not at high risk of volume depletion, for example, they don't have a high output ostomy, you can reduce weekly PN infusion by, say, 1 day a week. And then for both of these strategies, you're going to monitor their nutrition and hydration status. Their laboratory studies have all remained stable. After that 2 to 12 week period of time that I mentioned, you can continue doing the same weaning strategy. And then at the end of the day, you are either successful getting them to whatever point you're able to get them to, whether it's completely off or just down to, say, 3 or 4 nights a week. If you're stuck at 3 or 4 nights a week and you can't reduce their parenteral support any further because then it causes laboratory abnormalities, they start losing weight, start feeling miserable. This is, at this point, I think you should consider an intestinotrophic agent such as teduglutide. This extends with this previous slide and continues the approach to weaning parenteral nutrition. So you've attempted to wean parenteral support, and say you're successful. You've gotten them off parenteral nutrition or IV fluids completely. You still need to continue all those things you were doing before with the medications, modified diet and fluids, etc. And you continue to need to monitor them, including periodic monitoring, laboratory studies, micronutrient levels, and monitoring for complications. On the other hand, if it was unsuccessful and complete, this is when you're going to consider, as I mentioned, teduglutide, use of a GLP-2 analog. Or you can consider a non-transplant surgical option, intestinal lengthening procedure, for example, for the appropriate patient. Or you can simply continue parenteral support if they're doing well on it and tolerating it well. And then with these strategies, they're either successful or unsuccessful, and if still, or incomplete, and if still unsuccessful or incomplete, you need to continue the parenteral support and continue to monitor them. At this point, if they're intolerant of the parenteral support, that's when you want to consider referral for a transplant or surgical rehabilitation evaluation. So I'll leave you with these final take-home points. Parenteral nutrition use in short bowel syndrome is complex and benefits from multidisciplinary team approach to optimize outcomes. A detailed understanding of PN indications, formulations, monitoring, and complications and weaning will improve the lives of your patients with short bowel syndrome. And you should consider referral to a center of excellence when feasible. And I just would like to say thank you for listening. And please, if this piqued your interest on the topic, please go back to the original article that provides much more detailed information on these topics that I covered here. Thank you.